Today with Stephen Estime. He's the Associate Professor of Anesthesia and Critical Care at the University of Chicago Medicine and the Associate Chair of Strategy and Finance in the University of Chicago Medicine Department of Anesthesiology and Critical Care. Stephen, thank you for joining us today.
Thank you, Jordan, for having me.
As background, the University of Chicago Medicine Health System is headquartered in Chicago, Illinois, has 2,000 beds across 10 hospitals serviced by 3,000 providers. Now, Stephen, today we're going to be speaking about using data to shape staff behaviors and design incentives across a complex work environment. In particular, I understand you've been using operational data to improve staffing and incentives in the anesthesia department. Can you please elaborate on the genesis of this project, what the intervention is, and how it's going?
Yeah, for sure. So I think it's helpful to sort of provide a little bit of groundwork in what's happening. So as you had mentioned, I'm a clinical anesthesiologist. I also work in the intensive care units at the University of Chicago. Another hat, I sort of wear several hats, but as a day-to-day clinical operations leader in the operating room, I do that several times a month, just sort of coordinating cases, scheduling resources and staff to cover said operational cases. And then on the back end, thinking about high-level strategy and finance with respect to the Department of Anesthesia, how we're staffing things, and trying to maintain as best as we can operational and fiscal sustainability and responsibility. So, the one interesting part with the field of anesthesia is that it's sort of unlike other fields in that a lot of our workflow is captured in time. There are other if you're a surgeon or if you're a proceduralist, a lot of their workflow and the way that they are compensated is going to be based on how many cases they do. They're RVUs, if you will. If you're in a medicine-based specialty, a lot of that is determined by the complexity of patients that you see, the complexity of the medical decision making that you're doing for said patients, and basically the volume of patients that are coming across your workflow. So the fact that anesthesia is time-based, meaning that we bill and many times we're incentivized based on how long is the anesthesia team, the anesthesiologist, and by extension the nurse anesthetist in the room during a surgical procedure, start to finish. That's sort of how anesthesia is sort of done. What this means, and sort of the problem that I wanted to highlight and talk about is, trying to account for the work that's done by your frontline clinicians. We in the past were using, I'll call it a legacy system, where we use Epic, which is our electronic health record, and we were basically reverse extracting data for surgical cases that were being complete, and looking then to try to identify how much time our clinicians were spending in the hospital, and by extension, how much we should be compensating our faculty based on those numbers. That led to a number of different issues because one of which is, our time as anesthesiologists aren't always cleanly defined by time done in an operating room, which means that things like emergencies, so if you're responding to a trauma in the trauma bay, if you're responding to emergencies throughout the hospital, if there was waits or delays either between cases or to start cases, that's time that we're in the hospital, but that's not time that's being recognized. And so what that led to was us adapting, what that led to then was multiple systems trying to capture this time outside of the operating room. And it sort of kind of blew up into having 3 to 4 different systems trying to track and account for our time, which led to a pretty heavy lift from an IT perspective and from a data analytics support personnel perspective. And that's difficult in an environment like this. And so instead, we decided to transition and implement a more clinician-facing time and attendance platform to better make some of this information user-generated and hopefully increase some reliability in the data that we were capturing and then ultimately making decisions on.
What kind of, you said you're trying to create user-generated data. what kind of platform did you implement in order to enable that user-generated content?
Yeah, it's a third party platform that we're using, so it's not something that's homegrown. It's not something that that we created. It was basically a scheduling software that we've been using for years. Although the scheduling platform had recently released a time and attendance, meaning that clinicians could sort of self document their own time, meaning that they could sort of own that. And so when they were doing work for us with anesthesia, uh, that work that's particularly costly are night and weekend work. And so when clinicians were doing said night and weekend work, they could capture that time. It's a platform that you can also use both desktop and on a phone, and you can capture the work when it starts and then the work that when it finishes. And it's user generated, meaning it's coming directly from our clinicians. It's not something that we're extracting, sort of in the background and then trying to extrapolate the work that our clinicians are doing. And so I think it does a couple of things. It creates a little bit more integrity in the data because it's the work that is physically being done by our frontline clinicians. And it also helped us because we were able to whittle it down to sort of one source of truth, if you will, one data source, where we could then take that data and actually started looking at things and looking at trends versus trying to parse data out from 3 to 4 disparate systems. So it sort of helped to make things a little bit smoother and more efficient.
So, what are the data sources for this staffing scheduling user-generated data platform? Is it just, I mean, to what extent is it integrated with Epic, and does it have any other external data sources other than kind of clinicians going directly into this third-party staffing system and entering when they are in the hospital and when they aren't?
There are other sort of functionalities that this platform does, and so there is some data integration between Epic and between this platform where there's sort of bi-directional communication. Those are other sorts of use cases that there will be some back and forth. But I think specifically for the time and attendance of
Mhm.
better capturing user generated time, this one there isn't really bi-directionality. And part of that was intentional by design because I think that again the data that we're getting from Epic with respect to this particular issue was incomplete. And I think in many instances probably caused a little more confusion, and it was probably less helpful than just getting this stuff directly from the user.
So, how is the user-generated data validated?
I mean, we basically do audits. So we'll take a look and we'll do audits on the times. It's helpful because I am a frontline clinician, and so
Mhm.
I sort of understand the work patterns, and I can actually see it in Epic as well too. How many cases were going, what was happening on any particular day, and it's pretty easy to just sort of take a look at a day by day and a month by month basis to sort of scan and look were these things accurately placed in. There's also a free text option that's in this platform so that if there's discrepancies or if there's areas where um, things don't completely line up, then that can be an explanation that the user can create. And so it makes that process a little easier.
What percentage of cases are subject to this spot checking manual auditing against Epic?
I don't know if I can peg down a specific number, but I would say that, me and my team will review every single data point,
Hmm.
so we'll take a look at a high level and just and look through what those time punches are, how many hours were spent, and really we sort of flag areas where there seems to be an outlier. And if there seems to be an outlier where there seems to be a time where, wow, this certain clinician spent significant amounts of time either in this case or in the hospital this day. We can dig more into that. So we're really flagging for outliers,
Hmm.
um, when we're doing these audit checks.
It sounds like when you're flagging for outliers, you're trying to identify trends or, as you say, outliers. It seems like a perfect opportunity to leverage Gen AI. Have you thought about doing so?
I'll be honest with you. We launched this about a year ago, so we've got about 6 months worth of data at this point. So I think, AI is everywhere. And I think trying to use AI to sort of operationalize and make things easier is certainly a thing that this could potentially be ripe for. I think we're going to need more time with this data before we do it. And then also, the questions with respect to data security. We want to make sure that if we're feeding this into some kind of AI system, that we're doing it with a lot of responsibility with respect to confidential data.
Just to back up at a high level for our listeners who don't work closely with anesthesia, you did mention it's a different kind of specialty. It's measured and reimbursed differently than the other specialties. So just at a high level, is all time spent in the hospital or another care setting by an anesthesiologist or nurse anesthetist or someone involved in delivery of anesthesia care equated with reimbursable time delivering care? Or is there any time where the provider is at risk and is not meant to be reimbursed for that time?
That's a great, Jordan, that is a very perceptive question. So no, I think that the way, by and large, that anesthesiologists are reimbursed physically by their time, by third-party payers, et cetera, is by that time that's spent in an operating room when you're actually doing said procedure. When that makes it tricky because, I think, as I alluded to before, while that time is the reimbursable time and it's really the highest value time for what you're doing and how we're going to be paid, it's difficult when you're trying to sort of build a department where the reality is that anesthesiologists have to do work that is beyond just work that's in the operating room. And so how do you account for that time? How do you show value for that time? How do you sort of build commitment with the other things that just have to happen in a hospital, like responding to emergencies that, when you're responding to an emergency. So, part of my hat when I'm, working as an anesthesiologist, I got to respond to codes in the hospital. Technically, those codes, I'm, being reimbursed very, very little for those codes, if at all.
Why wouldn't a claims payment be issued for care provided in response to an emergency in another part of the hospital, or would it? And it's just not translating.
I mean, I think sometimes you can, but it's pennies on the dollar, and so it's incredibly low. Plus, that would assume that everything is documented in the right way to actually get that going to claims data. So, like I think we do generate we do generate revenue from said emergencies. It's just, it can be difficult to capture, and it certainly doesn't capture the entirety of the preparatory work that happens when, I'm thinking sort of doing an emergency airway, for example. It doesn't account for that preparatory work. Sure, maybe the intubation or the airway itself might be accounted for where, yes, said procedure was done, but all the time that sort of is associated with that isn't always neatly captured. And one of the struggles of trying to manage a department where it's a sprawling enterprise or a lot of moving parts is how do you retain your faculty, and I think sort of thinking about all the important work that they do, trying to capture the important work that they do, and then trying to figure out how you reimburse in a responsible way for that work sort of goes in line with how to keep a department functioning, especially at a place as complex as the University of Chicago. Because, in a lot of ways, this, I think there's a morale component to it because, when you're working with hardworking clinicians frontline, there's this at times it feels this insatiable demand for expanding service lines and doing procedures, making sure that you've got making sure that you can actually get a supply of providers there to keep pace with that demand is really important. And I think recognizing the time and effort that clinicians are putting in for their work is an important part. And that's where this tool has really, I think, helped us in some regards with that.
So where is additional revenue being drawn from when more reimbursable hours are identified?
Well, I mean, I think that's a multifaceted question. Some of that is a little bit beyond me, but I know that, I think the reality is increasing surgical revenue and providing and expanding surgical services is that pop-off lever. I think certainly trying to be really responsible with these high cost personnel, the high cost services that you have, you've got to be responsible on that end. But I think it's really led by health system growth and trying to
So
make sure that you.
it's coming from payers, essentially. You're saying that you were going to get reimbursed $30,000 for this procedure, but now that you're able to better account for anesthesia care delivered, maybe it's $34,000. I'm just making up
Sure.
numbers. Right. Okay,
Yeah.
great. So you mentioned, oh, actually, one last thing on this topic, admin time. I'm just trying to wonder where pushback could be. Obviously, you have other providers across the health system, not anesthesiologists, I wouldn't imagine too much, but other kinds of specialists who have pajama time. And they often are doing in-basket messages after their kids go to bed at night at home, and that isn't directly reimbursable. There's no charge associated with that. And as you're seeing as you're seeing anesthesiology being able to capture more time that is reimbursable, are you seeing other departments say, hey, I want my time to be also reimbursable when I'm not doing an actual procedure associated with the CPT code?
I'm going to pause with respect to the other departments, just because I don't work in a lot of these other departments. I will say that my friends that, are gastroenterologists and, even in primary care who, a lot of their time, you're right, is now spent with doing things like in baskets and doing times that aren't directly reimbursable. I think those questions are coming up more and more. And I think in a lot of ways, it's probably contributing to some of the morale and wellness and perhaps lack thereof, the burnout that we're starting to see across medicine because of these tasks that are being done aren't directly reimbursable. It's hard to figure out how you account for that time and how that translates into compensation. I think it highlights a real struggle and a real challenge with, how do we count for that, and how do we do it in a responsible way?
So you mentioned that now you're able to more accurately capture time that is spent by anesthesiologists delivering care. You want to avoid reinforcing the wrong behaviors and incentivize the correct behaviors in a complex work environment. Can you speak to how the intervention, the scheduling system, and the user-generated data has been reinforcing the behaviors that you want to see and incentivizing them to work in the way that you want them to work, and how have it moved providers away from the wrong behaviors?
Yeah, I think that one of the things, because OR time is the time that is reimbursable, I think we make it pretty clear that documenting time that can be corroborated with what you're doing in the operating room is where we want the majority of that time spent. And so if you are doing procedures or you're doing work that is quote unquote unreimbursable by third-party payers, then that stuff has to be documented, adjudicated, and discussed to see whether that's the best way to spend your said time. So I think that's probably one way of aligning some of that stuff. I think also just honestly, a lot of this data has been nice just from a conversation starter, and I think having data isn't magic. It doesn't make everything better. But I know that one of the issues that oftentimes comes up in our group is this concept of fairness, and is fairness being distributed across with respect to work with individuals or with certain subsections within departments. I think people want fairness. That's something that also builds morale. And I think by having tangible data, it helps us to better identify whether these are just sort of gut feelings. Like if we have clinicians that are coming in and saying, hey, I feel like I'm working too much, or one section is working harder than another section. I think being able to have this helps us in these conversations and sort of ground level and ground sets it.
From a data integration perspective, you mentioned that there's just one platform, the scheduling platform with the user-generated data, and that's where you can capture more areas where anesthesiologists are performing reimbursable work, or you said sometimes non-reimbursable work. You also mentioned that you manually review the clinical records in Epic to see what care actually was delivered, and you kind of try to reconcile those. Is there any other data that's being integrated or reconciled? Are you pulling in claims data? Are you using Epic Payer Platform? Are you using external data sources to accomplish any of this work? Or is it really just there's this one standalone solution and there's periodic manual review between that and Epic and side-by-side screens, but there's no data integration? What are you looking at in terms of data sources?
Yeah, I think those are important next steps. I think right now, again, because we launched this platform about a year ago, and we've got 6 months worth of data right now. It's sort of manual side-by-side integration or side-by-side comparison. But I think certainly the future to try to figure out how to better integrate, some of this payer information is there. We haven't implemented that yet.
Mm-hmm. Got it. And what would be the business justification for finding a way to better integrate claims data and clinicals data and the time entry data together in one cohesive, normalized, aggregated, and deduplicated data stream?
Yeah, I mean, I think that tying all these things to reimbursable behavior and making sure that you have a better understanding of sort of how time is spent that will sort of lead to and increase revenue, and where time that doesn't reflect that, sort of how to account for that time. I think that can I think that there's opportunities for that.
So we've approached the end of this podcast episode. I'd like to pose a final question to you, Stephen, which is, what advice would you have for yourself in May 2025, 1 year ago, when you were starting this program?
Yeah, I think, one of the things that I think I learned is, I think data and systems are great, and I think that using more and more powerful data is the wave of the future, and it's something that we've got to increasingly recognize. But I think at the end of the day, it's people first, And one of the things I don't think we talked much about here, but one of the things that I really that I struggled with and that I learned was this stuff doesn't work without buy-in from your people. And I think taking the time to empathize and sort of understand where your users are coming from, and that helped a lot for myself as a clinician in this, working in this complex environment. I think starting with trust and empathy can ultimately, I think it does a lot of the hard work, the hard lifting for you.
All right. Well, thank you, Stephen. I appreciate you joining us for this episode of Healthy Data Podcast. For our listeners, this has been Dr. Stephen Estime, an associate professor of anesthesia and critical care, an associate chair of strategy and finance in the Department of Anesthesiology and Critical Care at UChicago Medicine. Stephen, thank you so much for joining us today.
Thanks for having me, Jordan.